Picture this. You're in a crowded shopping mall, and suddenly a person collapses right in front of you. They're completely unconscious, they aren't breathing normally. Well, what happens in the very next few minutes is absolutely going to determine whether that person lives or dies. You see, every single minute that goes by without effective CPR and defibrillation dramatically drops their chance of survival. Early action isn't just important here, it's literally critical. So today, we're going to walk through the absolute gold standard Doctor's Complete Guide to Cardiac Arrest, and we're basing this explainer directly on the clinical principles of Harrison's Manual of Medicine.
Here's our quick roadmap for mastering this life-saving protocol. We'll start with what cardiac arrest actually is, then look at the major causes and science. After that, we'll dive into immediate basic life support, how to use an AED, what advanced hospital care looks like, and finally, a quick summary to save lives.
All right, Section 1. What exactly is cardiac arrest?
Okay, let's clear up a massive public misconception right off the bat. A lot of people tend to confuse a cardiac arrest with a heart attack, but they're very different. A heart attack is essentially a plumbing problem, right? It's a blocked artery damaging the heart muscle. But a cardiac arrest, that is an electrical problem. So what happens in those first few minutes when that electrical system fails? The heart just abruptly stops pumping blood. Harrison Sleuthleys makes this grim reality painfully clear. With that sudden loss of circulation, consciousness is gone within seconds. The brain, the vital organs, they're immediately starved of oxygen. And if we don't restore that circulation, permanent brain damage starts kicking in after just 3 to 5 minutes. Why so fast? Because the neurons in your brain don't have oxygen reserves. Without that constant supply of fresh, oxygenated blood, those brain cells rapidly depolarize and die. In this situation, time is, quite literally, brain tissue.
So we really need to understand the clinical definition of cardiovascular collapse. It's this sudden, abrupt loss of effective blood flow and consciousness. And as Harrison's notes, this unexpected collapse most often results from something called ventricular fibrillation, or pulseless ventricular tachycardia. In these states, the heart's electrical chaos causes its lower chambers to just quiver rapidly or spasm wildly, instead of acting like a strong, coordinated pump. No blood is moving forward to the brain. The pump has just effectively failed.
Moving on to Section 2, the major causes and signs. Now, let's pivot and look at this from a physician's perspective. Why exactly does the heart's electrical system suddenly short-circuit? We can actually break down the complex pathophysiology from the textbook into structural and functional buckets. Structurally speaking, underlying coronary artery disease or cardiomyopathies are the prime culprits. For example, a massive heart attack, which remember is that plumbing issue, deprives the heart tissue of oxygen. That dying tissue becomes electrically unstable, which triggers this fatal electrical short circuit. Now, functionally, the heart's really delicate electrical grid can be thrown off by severe electrolyte imbalances, like hypokalemia, which is low potassium. Other functional triggers include severe hypoxemia, meaning dangerously low oxygen levels, toxic responses from a drug overdose, or a massive pulmonary embolism that completely blocks blood flow out of the right side of the heart.
But, out in the real world as a bystander, you do not have time to diagnose the underlying cause. You need rapid recognition. You're looking for a sudden collapse, total unresponsiveness, and no normal breathing. And a quick note, if they're just occasionally gasping, that is not normal breathing. That's an agonal reflex, and it's a huge red flag for cardiac arrest. Here is a really vital distinction for the general public. Do not waste time hunting for a pulse. If they're unresponsive and not breathing normally, just assume it's a cardiac arrest. Now, for trained medical providers, you have exactly 10 seconds to check for a definitive carotid pulse. We have to recognize these signs immediately without wasting precious seconds, because delayed recognition is universally fatal.
Section 3. Immediate basic life support.
So let's get into the actionable, life-saving solutions. This is where you, the bystander, step in and literally take this person's life into your own hands. But wait, before you even touch the patient, you have to ensure this scene is safe for you. That is step 0. Once it's safe, check for responsiveness and take charge of the situation. Number 1, phone the emergency medical line, like 911, and get help rolling. Number 2, point to someone specific and tell them to retrieve a AED if there's one around. And number 3, begin chest compressions immediately. Don't hesitate. By acting fast, you are initiating the single most critical chain of survival.
Let's talk about the physical technique here. 5 to 6 centimeters, or about 2 to 2.4 inches. That is the exact compression depth you need for an adult. Place the heel of one hand right in the center of the adult's chest. Interlock your other hand on top. Lock those elbows and push hard. What you're doing is manually compressing the heart between the sternum and the spine to literally squeeze blood out to the brain. And what about breathing? Well, if you're a trained rescuer, the gold standard ratio is 30 compressions to 2 rescue breaths. But if you're untrained bystander, hands-only CPR is highly recommended. Just keep pushing.
And you've got to go fast. We're talking exactly 100 to 120 compressions per minute. Fast, uninterrupted compressions are just absolutely vital for maintaining brain perfusion. Also, you have to let the chest fully recoil between pushes so the heart can actually refill with blood. Just think about the physics involved. It takes multiple, consecutive compressions just to build up enough pressure in the vascular system to push blood all the way up to the brain. So every single time you take your hands off that chest, the blood pressure in the patient's brain rapidly drops to zero. You want to minimize interruptions. Do not stop. Keep pushing to maintain that critical perfusion pressure.
Section 4. Using an AED.
Now, chest compressions buy you time, and they protect the brain, but honestly, they rarely restart the heart's normal electrical rhythm on their own. For that, we need the automated external defibrillator, or AED. Early defibrillation is paramount. Harrison's points out that for shockable rhythms, like ventricular fibrillation, delivering an immediate 150 to 200 joule biphasic shock is essential to snap the heart out of that electrical chaos and restore a coordinated rhythm. And they're incredibly simple to use. You just turn the machine on, peel the pads, and stick them on the patient's bare chest exactly as the diagrams show. Ideally, a second rescuer sets this up while the first person keeps doing compressions. From there, you just follow the voice prompts. Crucially, when the machine analyzes the rhythm or tells you it's preparing to shock, you have to loudly ensure everyone is clear and nobody is touching the patient. Once that shock is delivered, immediately resume CPR. Don't even check for a pulse. Let the machine do the thinking, you do the pushing.
Section 5. Advanced Hospital Care.
Let's briefly look at what happens once the emergency medical professionals arrive, take over, and transition the patient to the hospital. This follows the Advanced Cardiac Life Support, or ACLS, algorithm, straight from the source text. If the rhythm is ventricular fibrillation or pulseless ventricular tachycardia, hospital teams are going to cycle through intense 2-minute intervals of CPR and defibrillation shocks. We're going way beyond basic CPR here. We establish an advanced airway, like an endotracheal tube, so we can secure oxygenation without ever stopping compressions. The team also gets intravenous or intraosseous access to push-potent medications. We're talking epinephrine, 1 milligram every 3 to 5 minutes, or antiarrhythmics like amiodarone to help stabilize that volatile electrical activity. But what happens if we see electrical activity on the monitor, but the patient still doesn't have a pulse? That's a condition called pulseless electrical activity. And here, doctors have to systematically act as detectives. We use rigorous algorithms to hunt for reversible causes, which we often call the H's and T's. We're looking for underlying crises like severe hypovolemia, massive fluid loss, or a massive acute myocardial infarction, or severe hypoxia. You have to identify and treat that root cause immediately, maybe with IV fluids or specific antidotes, because until you fix the underlying issue, you are not getting that pulse back.
Now, if the medical team is successful and we actually get a return of spontaneous circulation, the care is far from over. Post-arrest intensive care is actually fascinating. Harrison's highlights therapeutic hypothermia, which is also known as targeted temperature management. We intentionally cool the unconscious patient's body down to between 32 and 36 degrees Celsius for at least 24 hours. Why? Well, when a brain has been totally starved of oxygen, suddenly reintroducing blood flow can paradoxically trigger this massive damaging cascade of inflammation and free radicals. Cooling the body lowers the brain's metabolic demand, which blunts that inflammatory cascade and protects those delicate neural pathways from even more injury.
Section 6. Our summary to save lives.
Okay, we've covered the complex medicine, the pathophysiology, and the advanced hospital treatments. But for the general public, it all boils down to a few really vital, empowering steps. This is your action plan. First, ensure the scene is safe. Then, recognize cardiac arrest quickly. Call emergency services immediately. Start CPR without delay. Remember, push hard and fast right in the center of the chest. Use an AED as soon as you can get your hands on one. And just keep continuing CPR until trained medical professionals take over, or the person shows clear signs of waking up. You are the absolute most critical link in this entire medical chain. Without your immediate action on the ground, the most advanced hospital interventions in the world mean absolutely nothing. I'm going to leave you with this final, powerful thought. Knowing CPR can save a life. Learning these skills today may help you save someone tomorrow. Thank you so much for joining me for this explainer. I really hope this deep dive into Harrison's Manual of Medicine leaves you feeling prepared, educated, and completely ready to act when second